Dear students, today we are discussing the inflammatory bowel diseases, the idiopathic autoimmune diseases of the intestine caused by the dysregulated immune response to host intestinal microflora. These diseases are multifactorial, with genetic predisposition which is manifested clinically by 5 to 20% of increase of prevalence in first-degree relatives. These diseases include the Crohn's disease and ulcerative colitis. Also, there is discussion to include the microscopic colitis to this group, which is more mild cause autoimmune and inflammatory disease. The ulcerative colitis and Crohn's disease have bimodal age distribution, and they are more prevalent in the age group 15 to 40, less in 55-65, another peak. Ulcerative colitis, it is pathogenetically related to atypical T helper 2 response. There is mucosal and submucosal affection and bleeding mucosa with erosions and ulcerations. This is very clearly seen endoscopically. And as far as just this is present, we see one of the major manifestations is bloody diarrhea. Ulcerative colitis affects only colon, starting from rectum, proctitis, then left-sided colitis, and extensive colitis. The clinical manifestations, as I told you, include bloody diarrhea, tenesmus, intoxication, and extraintestinal features. For Crohn's disease, it is T helper 1, T helper 17 response with granulomatous inflammation, as here you can see the granulomas. It affects all the GI tract from oral cavity to rectum, all layers with fistulas and adhesions. Includes the diarrhea. The bleeding, it is not common and it is mostly in colonic forms. Fistulas, adhesions, obstructions, pseudo-obstructions, pararectal abscesses, extraintestinal intoxication, and malabsorption. Typical is patchy inflammation throughout the bowels, like for example the rectum, then just part of the descendants, then the iliac zone, and so on. And there are different clinical forms like ileocolitis, ileitis, upper gastrointestinal Crohn's disease, perianal colitis, and so on. The extraintestinal manifestations include autoimmune and non-autoimmune. Autoimmune include the erythema nodosum, pyoderma gangrenosum, iritis iridociclitis, aortitis, sacroiliitis, peripheral arthritis, and sclerosing cholangitis. Non-autoimmune include the anemia, inflammatory type of amyloidosis, liver steatosis, venous thrombosis, cholelithiasis. Complications of ulcerative colitis include bleeding, toxic dilation due to accumulation of polymorphonuclear neutrophils in mucosal and submucosal layer and production of the nitric oxide. This leads to the non-obstructive colon dilation with fever and very high risk of perforation. Also, the perforation can be the complication, the colon cancer and polyps as the precancer condition. The Crohn's disease complication include the penetration, this is so-called penetrating phenotype, with fistulas like here intestinal cutaneous fistula, also intestinal bladder, intestinal vaginal, and so on. Stenosis, this is the stenotic phenotype. Bleeding, which is rare mostly in colonic. Abdominal masses due to fistulas and adhesions between intestinal loops. Anal fissures, and also colorectal cancer. The activity of the diseases are measured by the scoring system. The ulcerative colitis is measured by Mayo score with frequency of bowel movement, rectal bleeding, endoscopic findings, and global medical assessment. For Crohn's disease, this is DICE score, frequency of bowel movement, abdominal pain, general well-being by patient's assessment, complication, antidiarrheal drugs, abdominal mass, and deviation of body mass and hematocrit from standard values. The clinical assessment of the patients includes the evaluation of the inflammatory syndrome by the hemogram, ESR, CRP, evaluation of cholestatic syndrome, the liver enzyme and alkaline phosphatase GGT-P, coagulation, autoimmune syndrome by antinuclear cytoplasmic antibodies which are positive for ulcerative colitis, not in all cases but maybe, for Crohn and for Crohn disease, antibodies to Saccharomyces cerevisiae. Also in all the patients with both diseases with acute course or first attack of the disease, it should be evaluated the bacteriological and microscopical stools investigations for acute infections and toxins of Clostridia difficile to exclude the pseudomembranous colitis. The fecal calprotectin is a marker of activity of the disease. Also, endoscopy should be performed with biopsy from rectum and for more sites and from ileum. Also, for Crohn disease, ultrasonic investigation is obligatory, which is not obligatory for ulcerative colitis. The MRI to see the stenosis and penetrations, and gastroscopy to assess the upper GI tract affection by Crohn disease. The treatment is a little bit different. For ulcerative colitis, the measure is mesalazine, which is used in any type of the activity, and it is used orally and rectally. Glucocorticosteroids for moderate and high activity, with the start dose in moderate 0.75 mg/kg prednisolone, and in severe 1 mg/kg prednisolone. The other glucocorticosteroids are recalculated to prednisolone by the number of tablets. And then after induction treatment, the dose is tapering. About budesonide, it is possible to use it, but it is less effective. The glucocorticosteroid use should be accompanied by azathioprine and other immune suppressors. And after the cessation of glucocorticosteroids, the immune suppressors are used for the long time. In severe course, anti-TNFs and other biologics are used. If not effective, colectomy. For Crohn disease, mesalazine is less effective. It's used mostly in colitis. More effective is budesonide MMX. And also the strategy concerning the glucocorticosteroid and azathioprine is almost the same. Also, in absence of steroid effect, there is the anti-TNFs and other biologics, and ustekinumab and guselkumab targeted for the interleukin 23-21 showed the high efficacy. Also, in cases of abscesses, bleedings, masses, and adhesive changes, the surgical treatment is used. So, okay. We finished.